Good afternoon, everyone. My name is Andrea McFarland. I am a second-year MSW student and an intern here at the Solar Office of Affairs. Today we are going to be talking about eating disorders in the social work context in a variety of settings. And here with me today I have three alumni. Nicholas Esposito, who is the admissions coordinator at the Renfrew Center of Rador. Eleni Zimmerman, who's a social worker at New York Presbyterian Hospital. And Zoe Bisbing, the primary therapist at Columbus Park Cooperative. So I'd like to just start out by asking you guys to introduce yourselves and just tell us a little bit about your role in your agency, in your setting.
Again, my name is Nick Esposito. I graduated NYU in 2009 with my bachelor's in social work. I also double majored in psych. I went on back to Philadelphia, which is where I'm from, to complete my MSW at the University of Pennsylvania. There, I was a second-year intern at the Belmont Center in Philadelphia, where I worked on their eating disorder inpatient unit there. After that, I worked in some outpatient mental health settings, doing some assessments for children with autism. Currently at Renfrew, I'm an admissions coordinator, so I'm doing the majority of assessments, diagnosis, recommendations for treatment, brief solution-focused counseling, and then also doing all insurance business, which is a good time.
My name is Eleni Zimmerman. I'm a social worker at New York Presbyterian Hospital. I took my undergraduate degree at Florida State. I studied psychology, and I worked for some time in a residential treatment facility for people with eating disorders, and some time in outpatient, and spent some time doing suicide prevention and crisis hotline. And then I came up here to New York and went to NYU. I graduated in 2012 and spent some time working in substance abuse at Lutheran in Brooklyn. And then I was at New York State Psychiatric Institute in their inpatient disorders unit for my second year placement. After that, I worked as a meal support therapist at Columbus Park Cooperative, and then eventually at New York Presbyterian Hospital as an inpatient social worker on their eating disorders unit.
Excuse me, I'm Zoe Bisbing. Eleni and I have crossed paths actually quite a bit in our work. I did my undergraduate work at Smith College, and then I got my master's here at NYU, graduated in 2011. My internships were not in eating disorder treatment. I worked in school social work and also general mental health clinic, but my second year here I did a volunteer internship position at Columbus Park Cooperative, which is an outpatient private eating disorder treatment center here in New York City. An intern there, and then my first job out of NYU was actually at New York Presbyterian Hospital on their inpatient eating disorders unit. And Eleni and I crossed paths very briefly, and then I left to work full-time at Columbus Park Collaborative, where I do individual therapy, group therapy, and what I specialize is in a treatment called family-based treatment, which is for adolescents with anorexia. So I do a lot of the family work and work with adolescents at Columbus Park Collaborative.
So it seems like you didn't all come into the school of social work thinking that you were going to be working with this particular population or in this field. So can you talk a little bit about how you did already talk a little bit about how you eventually came to that, but can you just elaborate more on how you determined your career path and working in this particular field?
Sure. My first eating disorders electives was upstairs, which I always thought was really fun, so I was happy to come back. I thought I would want to work with children and adolescents, and I have, but my second year placement definitely was really helpful. We saw adolescents, obviously eating disorders definitely can happen as young as 13, so on the inpatient unit that I was at, we saw children as well as adults. And I just thought it was a very interesting work to see the intersection between eating disorders, family work, eating disorders, trauma work. The connection there was really enlightening for me and a great learning experience on that unit. So I've always thought I'd come back to it. Renfrew in Philadelphia, we have that residential site and the outpatient site, so it's a big hub there. So it was an obvious fit after my internship.
So I kind of knew I wanted to work in eating disorders when I was working at a residential facility as a mental health worker. I was really an assistant to the social workers there, and they helped inspire me to get my degree in social work. And so I did, and when I came here, I was open-minded, but I still knew I wanted to work with eating disorders and spent some time doing substance abuse, and then had my second year placement in eating disorders and knew for sure that this is where I wanted to be. And luckily it worked out and getting a job where I wanted, but I liked the variety of work that you can have inpatient with eating disorders. I didn't realize it would be quite so fast-paced, but that's probably another question. But I kind of knew that's what I wanted to do, and it just felt right.
I also knew that I was interested in eating disorder work before I came to social work school. I had been a dancer and had been exposed to sort of the unique challenges of that community, and had worked briefly in entertainment, the business of entertainment, before I came to social work school, and so had a sort of deep appreciation for like the unique struggle of performing artists, and thought that that's sort of that was my limited understanding of what eating disorders looked like performance-oriented things. But then when I interned at Columbus Park Collaborative, I saw this whole other world into it, and then even more so on the inpatient unit, where you see it truly as a real psychiatric illness, that some dancers show up on the unit, but for the most part, it's more of a general community. So I think I had a hunch I was interested in it for one reason, and then when I actually explored, I discovered I was interested in it for many more reasons. It's endlessly fascinating work, challenging for sure, but endlessly fascinating.
So what would you say are the most, what is it like to work in this field, and what are some surprising things that you learn once you enter the field, both good surprises and bad surprises, if there are?
Good question. I think definitely to see the intersection between macro practice and individual practice, at least in my role. Insurance companies tend to have a really hard time authorizing certain levels of care for clients. So I may do an assessment, and I know that she may benefit from an inpatient setting or a residential setting, but the insurance company is only really willing to authorize a day treatment program or intensive outpatient. So as a treatment team, you have to become very creative on how to support this client, meet her where she is, and talk about, financial resources. If the family has it, more likely than not, that's not the case. So you're becoming very creative and collaborating, explaining the insurance side to the family, the clinical side to the family, or the individual. So that's definitely been a challenge. Something that's been amazingly rewarding is to watch the progress. So if they are starting at a very high level of care, to see them come down, or to see them make progress in their weight, in their meal plan, in structuring their meals, in their medical stability. So that's been a really rewarding experience at Renfrew to see kind of the continuum of care.
Okay, that makes it up. I can relate quite a bit to the dilemma of insurance, and when I worked on the inpatient unit here at Presbyterian, that was a huge challenge because, and Eleni can speak more about it, but discharge planning was a big piece of our work. I work in a private practice setting right now, so there's, on one hand, we don't have to really deal with insurance limitations, but on the other hand, we're serving a very specific population of people that can afford very expensive treatment. And there is, we do slide our scale to some extent, but the truth is, we are servicing a specific population that can afford to pay privately. As a result of that, you have the time to really dedicate, to the patients and the families, and they're getting really what they need. But one of the biggest challenges is when people don't have resources There are so few resources in the city, in particular in New York, even in the state for that matter, for people with eating disorders, and we struggle with, our state really struggles with being able to offer like a good continuum of care. So we have inpatient units and outpatient programs, but we don't have like a residential treatment facility that we can refer to, and a lot of people do need that level of care. So that can be both a struggle, and then obviously being creative, it can be rewarding when you finally make like a good fit.
I think a couple of things that I thought I was getting into when I started inpatient, it wasn't exactly what I thought. Working at the New York State Psychiatric Institute, and I had an opportunity to work with patients for a long period of time, and I didn't have to worry about insurance because they got treatment for free there. So when I went to New York Presbyterian, I was ready to do my family therapy, my individual therapy in groups, and we prepared to do that, but I didn't realize what an advocacy role I would have there on the unit for the patients, and making sure they get the appropriate level of care, that they're able to stay in the hospital long enough to stabilize, and that really you play an active role in helping them transition and also preparing the family for what's next. So I didn't realize what an active role I would really have in setting the stage for the rest of their treatment. And some people think as a bed patient is just, they're coming in, you're discharge planning them out, but you really have the opportunity to make a difference in where they go next and how they're looking at it. So I think that was very surprising. I guess it's both good and bad.
What are some important areas of study that you think help build the expertise that's needed for working with
In terms of here, or just training?
Just training in general.
I find that like really from a clinical perspective, having a good understanding of cognitive behavioral therapy interventions and dialectical behavioral therapy interventions, and I was describing family-based treatment, which is sort of an emerging intervention for adolescents with eating disorders. It's a very behavioral heavy kind of field, and that's not to say that there isn't a place for more psychodynamic work, especially once people are more weight restored and can better engage in a therapeutic process. So having an eclectic approach can work, but really knowing different interventions and when they're appropriate. You'll be collaborating a lot with dietitians and other kinds of practitioners that work on interdisciplinary teams to treat these patients, and especially for anorexic patients during weight restoration, behavioral interventions are really important. And I'm reflecting, even being here, there was a course in eating disorders here, which is like a nice kind of survey foundation, but even there was a CBT course here as well, and just getting oriented to all of those things. I mean, supervision once you're actually in the field is key, but having a behavioral foundation is, I think, very important.
Yeah, I took a trauma-informed practice certificate down by Philly, and I thought that was really helpful, especially being a male in such a female-dominated field, to be very mindful of my presence as a male and what that may do for a client. I thought was really important. Any sort of women's studies class I also thought was really important in this practice, especially if they do identify as male. I think that bringing men to the table is an important conversation that needs to be had. More often than not, I see mother and daughter dyads. I always find it much more helpful in an admissions meeting to have mom, dad, and daughter if if that's the constellation of the family. So I definitely think any sort of family training work that you have, the intersection between eating disorders, body work, trauma, I think is really important. Obviously, cognitive behavioral therapy, especially with clients with bulimia, as we showed empirically, is being really effective. There's a lot of research out there on eating disorders and interventions for sure.
I agree with all of those things. I mean, I think on a smaller scale, thinking about how to conceptualize cases and prioritize needs is really important, because you often are dealing with people that are medically compromised, depending on what level of care they're working in. And I certainly am dealing with people who are medically compromised, so you have to think about, what do they need first and next, and being able to think of it all at once. It's a skill to practice and feel confident in by the time you get out there. there to do it. But otherwise, I agree with all the basic questions.
I have more questions, but after I ask these questions, if you guys have any questions, please feel free to. Are you a part of any professional organizations or institutes that you feel have contributed or helped you? And if so, how?
Well, NESW helps with some things. They have liability insurance, and there's a lot of different talks you can go to, and I mean, it's really helpful connecting you to other social workers.
I found in Philly both there's the University of Pennsylvania, there's Temple University, and then Bryn Mawr College. They all house, just like NYU, Columbia, the schools around here in Florida, they house different training certificates. I think that that's been really helpful. Definitely getting my LCSW supervision, I felt, launched me into a career path very quickly. So getting that supervision early on, I thought was really great. There's the Pennsylvania Society of Clinical Social Work that's been really helpful as well for networking opportunities, for private practice, etc. So that's been really great too.
And I'm a member of the Academy of Eating Disorders, which is a really great organization that is an international organization. They have an annual international conference, which is, I went to for the first time this year in Montreal, and it's going to be in New York in March. So next year it'll be here in New York, and it's a phenomenal conference of just clinicians and researchers from all over the world presenting their findings. And it's a great kind of global community. And then I'm in the process of becoming affiliated with the Women's Mental Health Consortium, which is less eating disorder driven, but it's a community of different clinicians and also has quarterly conferences to bring different clinicians together, which is great for referral sources because a lot of our patients might require a psychiatrist referral or any number of things. And it's good to have communities of private practitioners that you can collaborate with.
Does anyone have any questions?
I was just going to ask, what's your advice for someone who definitely thinks they want to go into the field but won't be able to do it during internship? Is there another way to get access so that when they're eligible in the job market, we do better? And maybe
I know that at Renfrew specifically, there's bachelor's level positions that are open for counseling. That's always helpful. I think anything that would give you exposure to eating disorders, substance abuse, trauma, because it all kind of goes together sometimes, would be really helpful. So I know when I'm looking at resumes for positions, that's what we're looking for. Do they have a background in family work? Do they have a background in working with a variety of populations? Do they have an addiction background, etc.? So just because it's such a hard population to get into, it's very limited, I think, in terms of treatment. So if you have skills that can be used with this population, I think we should be going.
I would say also, volunteering anywhere that you can, a hospital or another facility. And then also kind of broaden what you think may include eating disorders. So maybe it's not an eating disorder program, but maybe you can get some specialty training and offer that service in a community-based program. Because I would tell you it's so needed that there are more community providers that are confident in treating eating disorders and very interested in that. So I just wouldn't narrow it too much into the very few eating disorder programs that are out there.
Those volunteer opportunities are out there. I mean, in terms of what I did, I also didn't do my internships in eating disorder treatment, but because I was interested in it, I sought out a volunteer internship position at Columbus Park Cooperative, and I know that I think we have sometimes groups of interns that come that maybe they're doing a dietetic internship somewhere or a social work internship somewhere, but they come weekly for a supervision group to kind of get to know a little bit about our work. And I can't imagine we're the only center that offers that. So really offering your time, not too much of your time, but offering your time, expressing an interest in wanting to learn about the field. I think that's a great credential because that's as good, in a way, it's as good as having an internship somewhere else because it shows that you're really interested in the field.
Someone else had a question?
can you
elaborate how often they've needed more, how you guys address each client as a team of professionals, like the doctors and the psychiatrists and other, fields of expertise?
Sure. So, for example, when I have a client, she may be scheduled, I'll use one from yesterday. If they get scheduled with me, I do the initial assessment. That assessment can be, there are some cases where you have to work real fast, where she's medically complicated. You get her labs ahead of time, so usually we try to get their medical paperwork ahead of time so I can review it with our nursing department. If I notice that her heart rate is dangerously low, that's a very different conversation than I'm having with someone whose labs are stable. So I like to get that medical paperwork up front so I see where she is medically, then have a conversation about symptoms, really teasing apart what's going on. If I feel like they are stable, then I usually consult with our psychiatrist and psychologist about, this is what I thought a good level of care for this client was. This is, where the family is at the moment. Sometimes they agree with you, sometimes they don't. Denial is a big part of this disease. So I think trying to meet them where they are, seeing what they need, and then making it work together is really helpful. So I try to get the medical paperwork up front. I'm always consulting with our dietitians. I usually kind of catch them on the fly, which is really helpful. It's a great working relationship. But I definitely have time set aside to meet with our nursing department, our psychiatrists and psychologists to go over kind of the nitty-gritty clinical stuff.
Working in a hospital, I work very, very closely with the doctors, the psychologists, the dietitian. Every morning we meet with the patient all together. So we're always working together. And then after we meet the patient, we go on our own and talk about it and figure out how to work together as a treatment team. But I would say something to consider, because you would work so closely with doctors and dietitians, is getting the basic knowledge about the medical terminology and things that go on with patients with eating disorders, what medical complications they may struggle with, as well as dietary needs. Because even though that's not your specialty, it's something that you should be aware of and be able to talk about with patients and families.
Working out, I actually missed that quite a bit, the interdisciplinary team that was so accessible on the inpatient unit. And working in the outpatient world now, it is harder because you're hunting people down sometimes. Like, we're all in different offices. I work in a collaborative practice with a nutrition component. But if we have a psychiatrist on the team, that's one, she or he might be over here, and there might be a medical doctor. A lot of our patients are very closely followed by pediatricians, adolescent medicine doctors, GPs, etc. So that can be challenging, but like really good clinical care coordination is really key in order to do our job, because that's kind of where you get to be a social worker also, making sure that you can be that advocate, making sure that all the different providers are talking to each other, because it can be disastrous. You can lose a whole week of progress in a patient if that medical doctor doesn't have this important information that you have, and oftentimes you can kind of be the hub of that, of that communication chain.
What's also helpful is to know what outside providers in the community are educated about eating disorders, because I may have clinical knowledge about this assessment that her pediatrician doesn't know about. So yes, her heart rate or her labs might be kind of off, but they don't know about her purging behaviors, or they don't know about her cutting behaviors. So just making sure those releases are signed in order to collaborate closely is really important. And knowing who in the community is educated with eating disorders, and if they're not, reaching out with whatever organization you're affiliated with to provide education to those providers is helpful.
Are there any other questions?
I'm curious about the sustainability of this field's career. I know there's some, I have very limited knowledge of the fields in social work. I know that some, people can only be in it for a certain amount of time before there's burnout or it's just too intense. And I know that we've all are relatively recent graduates, but the other professionals that you've worked with, are there people who are in this field I know that there will be people who are in this field for a while, but like, is there more long-term careers, or is this more of like a little blip in the
And that's a really good question. I mean, I think it's a good question because I have met professionals that have been at this for a long time, and you're like, maybe you should have split your focus and mixed it up a little bit. But the truth is, people that are in this work are really passionate about it, and that's why you meet a lot of clinicians that are like, yeah, I don't treat eating disorder patients. And in a way, it does require a certain kind of curiosity about these illnesses and just a sort of tolerance for the types of people that you're going to meet, the types of families you're going to meet. And I do think you can know pretty quickly if it's something that really inspires you and excites you, or if it's something that just feels like, you know, it's just not for you. So in my experience, like I've met a lot of clinicians that are much older than we are and have been at it for a long time and still feel that way. And some people do want to make sure, like if they are in private practice setting, let's say, that maybe 50% of their time is devoted to eating disorder practice, and then 50% is the more general practice, which might be a goal of mine at some point. But I think there are people that are in it for a long time. It's a good question though, because we are all recent.
You know, just like every other field, that there are different levels that you can work in it. Where I am, it's very severe, it's very intense. There are people who've been working there in eating disorders for a very long time, but there are some who do that for a little while and then transition, just like Zoe did, to outpatient, and take on some other cases maybe. So maybe you're not working with the most severe cases in a hospital for your entire career, but maybe you start doing that and then work your way down. I think, just as Zoe said, you kind of know where to get into it. If it's something that you feel like I can do this, or something, no, I don't think so. So you would know when you got into it.
Yeah, I just think having a general sense of self-awareness and supervision allows you to know when you're burning out. Both of my supervisors in my internship and then currently have been in the eating disorder field for 10 plus years. Specifically, my supervisor now is 20 plus years. So they've been in it, and I think that's been really helpful. And Renfrew's been around for obviously a while. So I think just being a part of that has been really helpful, to think that this is a place, now that I have my LCSW, I can ground myself a little bit more, and call it a home for a while, and then see what happens next. I think with eating disorders, like just keeping up on the research is also really helpful. I mean, areas of research are men with eating disorders, minority clients with eating disorders, income and eating disorders. I mean, there's a lot of research that can be done out there, and a lot of skill set to be developed for those different populations.
Could you talk about how important group therapy is in terms of a tool for treatment, and whether you facilitated any groups and how the patients seem to benefit from the groups? And I guess the second part, do a lot of people in the field believe that it's really an addiction and just like a drug addiction? And do you encourage patients then to seek help in the community through like AA type, spiritual programs?
I do know there's organizations like I believe Overeaters Anonymous that's out there. That's a 12-step program for binge eating. I don't do groups now. Group therapy is part of our entire continuum of care, from residential all the way down to outpatient. We offer groups for women 30 and beyond. We have adolescent groups. We have groups specifically geared towards the holidays that are coming up at this time. Group therapy is definitely a big piece of it. I think that having a group of supportive women who know what you're going through, just that in and of itself says so much. I did groups on the inpatient unit in my second year internship, and they're very different, I think, from our outpatient groups, just based on where the client is in the moment, and where they are in their stages of recovery. I do hear clinicians talking about that it is very addictive, and brain chemistry with binging can look very similar to brain chemistry with getting high. So I know that there's that aspect of the disease that's tough.
I mean, groups are extremely important, and in our unit, it's group-based therapy, and that's many of the eating disorder treatment centers are based. So I'd say a lot of the important work happens there. I do facilitate groups on our inpatient unit as well as an outpatient program, and I agree they're completely different. People are struggling with different issues, and you focus on different topics when you're inside a hospital as opposed to outside. But to answer your question about addiction, some of our patients come in and they do struggle with addiction in addition to their eating disorder. So oftentimes if someone comes in with that and they're already engaging in AA, maybe I would help them to think about their eating disorder in the same way, if that's helpful to them. If it's not, then we leave it aside. But certainly there are some people who do gain a lot from that.
And different types of groups too. Like in my program, we offer DBT skills training groups, we offer a CBT group, we offer body image group. I run out more of an open process group for women that are struggling with binge eating disorder, and like an slightly older group of women. So what I find to be really powerful about that in particular is that there's so much shame around these illnesses, and there's so much secrecy, and having that opportunity for these women to come together, and this is the one place that they're actually able to be open about what's really happening for them, and that's in more of an open process group. But those other groups would be really useful, more didactic groups. And then there was a second. It's actually interesting because I'll have patients come in and say, what do you think of OA? Or I went there. And again, like to Eleni's point, whatever works for you, great, and we'll run with it. But philosophically, OA, for example, is very different from like the philosophy of the nutrition team that we work with. It takes more of that addiction model and kind of cuts out certain foods that are going to make you more vulnerable to an addiction. And that's very different from the approach that our dietitians take and we take as well, which is more that you want to redefine what healthy food means, which means everything really in moderation, and that's very different. So that's actually really important, because if you have someone who's kind of coming to you for one treatment and then going to OA, they like the group support, but you kind of want to encourage them to take the information with a grain of salt, because then you can be getting two different orientations, and then that can be very confusing. So that's something important to keep in mind.
I have a question about supervision. I know that you all work in different types of settings. So what does supervision look like in your particular setting?
So every Friday, myself and there's another admissions coordinator, we meet together with our supervisor, and we go over the cases for the week that we've had, and if we're stuck on any, or if, a client not coming into treatment, we really brainstorm about, what would it take the case at this point, and how to make it, each case is so individual at times, how to really meet this family on an individual basis, whether it's bringing them back and having the client disclose to their family that they're struggling with this issue, or having them meet with the dietitian first before even coming into program, because she has questions about what her meal plan may look like. So it's really on a weekly basis, usually for about an hour and a half, with myself and my colleague.
Supervision is weekly for me, but one of the great things about working in the hospital is that it's not just my supervisor, another social worker who's supervising me, but I have doctors that I collaborate with and can supervision from. So I think that that's a nice opportunity in the hospital. There were a lot of different groups that happened throughout the week that you talk about patients, you talk about cases, and figure out what's next. And so supervision isn't just with my supervising social worker, but with others on the team.
I think supervision is so important. I had very negative experiences of supervision in my graduate training, which was kind of pretty common, I suppose, unfortunately. I find that supervision, my experience certainly on the inpatient unit, was that supervision felt very administrative with the social worker I would meet with. And similarly now I have weekly supervision individually, and we're starting a group supervision now, which is wonderful. But I've always felt like kind of more starved for more of like a real clinical supervision, and so I sought that out for myself. And I do have a private supervisor that I see, which is obviously a financial investment that is sometimes hard for me to manage and not accessible for everybody. But I find that when you have supervision in the context of a program, the nature of the work for that hour is very much like, how's this patient doing? How's this patient doing? And what about this one? And it's just by the nature of the work, it's very practical. And that's essential, but if what you're looking for is more in-depth kind of exploration of the work and how to conceptualize the cases, and I think that one of the harsh realities of the field is that you sort of have to look elsewhere for that sometimes, and that can be very rewarding as well. And I guess just to think about it as like continued education investment. It's really, for me, it's been very important.
Yeah, and when I was getting my LCSW, I did the same thing. I saw outside supervision in Center City, Philadelphia, which was very convenient because that's where I was living. So that was definitely a supplement to the supervision I was getting at work, and very different.
Yeah.
Much more personal, tailored, exploring, my own stuff as well as how my own stuff was impacting work, and definitely, similar to supervision is always your own personal therapy. I think taking care of yourself in this field is so important, especially with clients that have such a knack for not doing that.
How often do you find that families are on board with the treatment and supportive and willing to, if there are any changes that they themselves need to make? How often are they willing to make those changes? And if not often, then how do you go about still helping the client succeed with their treatment?
Yeah,
That's why I asked.
yeah. I've had a situation more often, unfortunately than not, where I'm sitting there talking with an adolescent, and mom is more stirred up than the adolescent, and we realize that this is becoming an intergenerational pattern. And for the daughter to get better means mom has to work on her own stuff sometimes. So she'll pick up on it really quick. And it's really hard, I think, to kind of discuss, again, deciphering the Maslow hierarchy of needs. Does she need medical work first and her basic well-being, and then where does she fit? And I think managing, the family work might take a back burner because she needs to be stabilized first. So really triaging that, figuring out how to implement that. But also, I think a big piece of it with the family is, ingrained in our programming is multi-family groups, family education. I think that's so important. That very early on there's family meetings, there's family groups, so not ending it just at the admission. So I might get a feel for it, but I'm not addressing it in the admissions. I may pass that on to the clinician that's getting the client. Sometimes I think it might be hard for families to realize that this client may need to take a leave of absence from work, or she's a new mother and she may need to take some time away from her baby to focus on herself. So really working on a motivational interviewing about, this is your life right now, and in order to be the mom you want to be, you have to take care of yourself before taking care of the baby. And really utilizing the strengths of the family unit, I think, is also important. So, if there is a husband or a significant other at home, can take the baby for some time while she's in our day treatment program, and then figuring out how to balance their family situation. For example, like family medical leave, I've written several letters for husbands to take some time off so their wife could get treatment, or writing letters to schools. Because it's another thing is asking someone to take a semester off of school, or taking a leave of absence from school. Just educating the parents that schools are usually pretty good with allowing the child or the student to take off. So kind of addressing their concerns in the moment, taking inventory of what could be later work, and really triaging the situation.
The family work is so valuable for the progress to be sustainable at home. And the level of care that I work in patient, I don't get to explore, the family dynamics any further than helping them get on the same page. And sometimes that's very hard. And I do a lot of psychoeducation and just making sure that people understand what's happening. And sometimes I have to create the urgency that they need to pay attention to this. And sometimes I have parents that I have to try to calm down and make sure that they're going to be able to handle this situation. So it really depends on what level of care you're working in, but the work differs as you go along. I think if I were seeing families outpatient, I would have a chance to really address the dynamics that impact the illness. But for my level of care, it's a lot of psychoeducation and making sure the communication is open so they can continue their treatment.
I find that even in the outpatient work that I do, it's a lot of psychoeducation too. And really a lot of repetitive message sending to the family because, like, to Nick's point about the denial, like, the families are often in denial as well. In a way, like, if you have a malnourished 14-year-old, there may be dysfunctional family dynamics that you can kind of observe, but that's actually not the priority right now. The priority is getting the parents really on board to help refeed their child. And so we often talk a lot about kind of medication management support, and medication being the food, and that, you know, if your child had to take 5 to 7 doses of medicine daily, would you really, like, let them just do that on their own, or would you be there making sure you're administering it? Obviously, we try to use a lot of these kind of analogies to drum up anxiety, because sometimes you're shocked. Are you scared? And sometimes you have families that aren't, and then you have those over anxious parents that you spend a lot of time trying to help them balance out how to just be the best caretakers for their kids. Once you have a sort of healthier patient, then you're in a better position to do more of that dynamic family work. And at that point, you know, the family's in a very different spot because this pathology, the eating disorder, has hopefully kind of been sort of taken away from the family, and we can kind of have a better view into the family and sort of helping them recalibrate once their child is well again.
It's also really interesting to that point is sometimes when I do my assessment, I hear a story from the patient. I get a completely different story from the loved one. And I tend to see that the realistic story is from the loved one. So really pointing out the discrepancy of, you know, you told me this, mom told me this, where's the truth? What is that? And really pulling out all the secrets. I think the more secrets they have, the sicker they become. And the more emotional weight they're holding in, the heavier they feel emotionally, which obviously plays into all of this. So analogies become your really, like, very good friend in kind of communicating, you know, if you, again, had diabetes, you would be taking your insulin all of the time, so you need to be taking your food all of the time.
I'm a third-year student OIR, and I'm feeling a little like I've been working with the same population ever since I started in this profession, and you know, this is very helpful. So I wanted to just thank you for sharing your experiences, because you know, most of my experience is working with people with developmental disabilities, which I do love, but it's kind of like I feel like there's something in me that's saying it's time to switch it up. But I think that in general, we all have to have the same skills, like the basics. What would be your one word of wisdom for us who are like about to graduate, you know, and to the field?
One word that's pretty difficult.
Or not one word, one few words.
No, I would say, well, yes, we all have the basic skills. I would say trust in your training, trust in your skills, because when you go in there, you know how to do those basic things. You know how to conceptualize a case. You know how to establish a rapport. You can do all these things, and I think just trusting in your ability to do it will take you very far. You know, not to worry about all the little details. Like, you have a supervisor to help you with that, and you'll do just fine. But to really trust in your training.
Yeah, take a deep breath. It's so much easier said than done, but I say to clients, and I like them to take a deep breath, you too. I think coming back to NYU has been really rewarding. I mean, having NYU and Penn under my belt, they know in Philadelphia that these are the social work hubs. This is where really good students come from. They know the caliber and the history that you're coming from. They know the training. They might have been here before. So I think that that's definitely served me. I mean, I got this position that I'm in now, I think, because of my second year internship. I, came from NYU and then went to Penn. So it's a lot about connections and who you know, and getting the experience, and it eventually works out.
I think knowing you're valuable and really self-care and having good boundaries are really important because I mean, we're all in this because we care and we want to help, and it's so easy to, you know, skip your lunch or, you know, work a few extra hours, and it's not actually worth it. I think that you can be a better clinician if you can be very boundaried, and a lot of the sort of mentors that I've gravitated towards in the last couple of years are people that I'm impressed by those boundaries, that they don't say they're available if they're not. They don't overextend themselves, because there's a difference between overextending yourself and being a really dedicated clinician. And I think that that's a lesson that, to your point about burnout, I think that that's something that we tend to learn later on in our careers, like by burning out. And I do think that a nice way to try to prevent that from happening is to make sure you're not, you know, that you're taking care of yourself and not overextending.
In more clinical terms, in treating these patients, what's the average length that you're treating them for is dependent on, I'm sure insurance plays a big role in that, but you know, inpatient, outpatient, how does that differ?
So inpatient, inpatient in the hospital I work in, where insurance plays a role, we help patients stabilize, and if they're coming in at a very low weight, that means that they have to restore that weight until they leave the hospital. So that can take, you know, anywhere from 1 to 3, maybe 4 weeks, but pretty short. And other people who may be coming in with binging, purging, the typical length of stay would be 7 to 10 days to interrupt the behavior and then connect them to the next level of care.
When I'm making a recommendation for inpatient, it's the same. It really depends on the binge purge cycles, really depends on weight, also depends on electrolytes and heart rate. So I've seen clients go inpatient from anywhere from a week to maybe 3 weeks. Residential program, I'm always making a recommendation of 30 days. For day treatment, I'm making a recommendation of 4 to 6 weeks, depending on how she does, you know, what needs to be worked on. If she slips in the program, we usually extend for about 2 more weeks to 6 weeks. Our IOP program, I think, is where a lot of the work is done. You're more creative, more experimenting. You're obviously stable enough to do this work at that level of care. So that's usually about 6 to 8 weeks, usually about 8 weeks. And then eventually into outpatient, which is always usually a multidisciplinary team. So a dietitian, a therapist, sometimes psychiatry on board with maybe outpatient groups.
And my center sort of picks up at the IOP level of care, and because we don't have the constraints of insurance, we do see much longer lengths of stay, which, by the way, is not always great, because then sometimes you'll have patients with more like access to pathology that are lingering in the program, and they can benefit from maybe the containment that insurance limitations can offer. But we'll have people that are really in individual ongoing therapy and have relationships with dietitians for years, and maybe are in our IOP for several months, and then step down to just like one group. Some of the women that are in my outpatient group, they're not in the IOP per se, but the group is sort of additional to their individual work. And I've had clinicians in the field that say on average, like really 7 years is like a typical kind of journey if you start an inpatient and end with the outpatient treatment. But you can imagine a lot of people that they have a real resolution with their eating disorder then continue to use individual therapy to explore all sorts of life issues. But 7 years is sort of the...
I've heard that as well.
Yeah.
Any other questions?
I have a question. I hear you saying she a lot of young women. How often? What do you? I assume that you mostly work with young women or women, and does it? Obviously, your treatment doesn't differ, but how does working? If you ever work with men, how does that differ?
Sure. I mean, Renfrew, obviously, there are higher levels of care, so residential, day, and IOP is women only. Our outpatient services, we do have men. I've been in my position for almost a year, and I haven't assessed a male yet. When I was working in an inpatient setting, we did have males. And I think it's an underexplored area. I think that there needs to be more attention focused to it, especially with LGBT populations. It's very dangerous. I see a lot of clients who are women, but have a brother who is also dealing with issues, so that comes up and always interesting. I also think I've had women whose fathers are bodybuilders or injecting steroids. It's a different set of symptoms, I think. And I think it just speaks to socially, how we're socialized, that women are to be thin and men are to be muscular, and I think it just, it's almost the same beast, but manifesting itself in different ways.
Sometimes men can fly under the radar because maybe it doesn't look exactly as we would expect, as it does with the women and girls that we see. And I work with both males and females in the hospital, and with adolescents and adults. So the ages that I see range from 13 to 80. It's a pretty wide variety.
What's nice about the AED, the Academy of Eating Disorders, and this international conference they have annually is they're presenting all of this research, and this is, like Nick was saying, it's a really emerging area. And so we do accommodate male patients, but we don't see a whole lot of them. And that's not because they're not out there. And that's it's nice to know that at least it's at the forefront of research that's kind of coming up. But
Does anyone have any last questions? Yeah, I'm just curious about what is your experience if you guys could illustrate how cultural differences influence in these, because eating is very family based, very social, and it's different from culture to culture. So you guys have insights?
I've had patients say that growing up they didn't have much to eat, so why waste something now? So food can be used as a sense of self-worth, a sense of power, a sense of money. It's really interesting how food can be used for other deeper emotions. In my own culture, being Italian, food is love, and you give as much to it as you can, to as many people as you can. So I just think culture is a huge piece, and really, in the work, I think, is where you're going to ask those questions of what was dinner like? Was it an anxious time? Was it a time when no one was allowed to talk? Was it, how did food play a role in your family? How does food play a role now? Thanksgiving is coming up. We usually notice more patients come in around the holidays. This time of year is pretty tough. So I think food and culture is a huge piece that definitely should be addressed.
I completely agree. Just like all your other work with any other patients is a very important piece, and then you have to get the knowledge that you need to be able to work with the patient and their family. And it's even more important because it involves food, something that they need in order to be successful most of the time. So I would say I see a wide variety of cultures in the hospital, and oftentimes have to use interpreters, and things get lost in translation, and then that becomes quite an issue, and trying to negotiate all of that. So I think it's something to always be focused on.
especially since this was more the case for me in the hospital, but certain cultures you encounter are very anti-therapy, anti-treatment, want to think of this more as a medical problem as opposed to something that might have more psychological underpinnings, and trying to meet them where they are, but also in the case of if it's a kid that has this issue, it's imperative that the child gets the help they need, so really being able to be entirely respectful of what the family wants, but also trying as best you can to educate them about what this illness is. And so really where psychoeducation becomes very important.
Something else that I found useful is getting anyone that's connected in their community to help provide a psychoeducation, or maybe it's like a sibling or a friend or something, someone that's within the community, but to help get the message to the family about the illness and the treatment is really helpful.
I think also, there's several cultures that do have food restrictions, so when doing an assessment, I'm always asking if someone's vegetarian, if someone keeps kosher. Those are all things to be extremely mindful of when you're talking to families about what does their dietary restraints look like, and how can we include her meal plan into that in a respectful manner?
So, unfortunately, we're out of time, but I think that we're around for a few minutes after if anyone has any additional questions. Thank you guys all very much.